you know that obesity, it is a disease process, and it is a chronic problem, and associated with it are psychological elements. And it's not that you go to surgery and these psychological elements just disappear. They are things that are deep-rooted, they need resolution, and they need to go through an evolutionary process to kind of be minimized over the course of the changes that follow weight loss surgery, or you learn coping mechanisms to deal with them. And some of the barriers that you come up with through the first year with your weight loss, with body image, with concerns that we often touch upon in support groups, the only thing is to also really be very honest with yourself through this process.
After surgery, there's a number of factors that come into that argument. First of all, now there's a physiological change. And there's also an investment that you've made. And it's like when you buy a house. You take a pride in it, you maintain it, most of us maintain it, try to take care of it, so the roof doesn't fall on us on a rainy day. And so the answer is, yeah, this comment is often raised, well, if I could just have one cookie and stop eating, I wouldn't be where I am. But the reality of it is, after surgery, it's a lot easier to do that. You can maybe have a taste of something, and you may find that you don't even desire it anymore. Your palate does change. Your pathways, your taste pathways do change. And you will feel, okay, actually, I'm happy. That one took care of my cravings, and I don't need to have a packet to get that same satiety or fulfillment. And then you go to it maybe next time. But having said that, there are patients that you're absolutely right. They start with one, and then they find comfort in that. They go to 3, then a pack, and they do every other day, and then every day, and put all their weight back on. So that's why, from the very beginning, there's an emphasis to make sure patients go into these well-informed, try and lose weight before by setting in some sort of a program for themselves that they recognize what is good healthy eating, what is not, and show weight loss, so that way afterwards it's a little easier transition. But ultimately, you can only offer something. You can't make someone take it on. And if they go to these meetings just to get to surgery and leave and go, I think that group is definitely at risk of having not the optimal outcome. They may lose the weight and they regain it, or they don't lose as much. And there is a 20% on average failure rate. Either they never lose weight or they lose it and regain it. And I have to say, when I have situations like that, it's very hard. And the key is to make sure that the patients do everything that they need to do. And I think when they do that, if not much shifts, then you have to accept that. But often there are areas that could be improved. And it means that you have to be very diligent, very focused, and very honest and transparent about things that you do. So that's really all down to you having a very clear vision of what you want to do and where you're going.
I want to share with you a phone call I had last month or 3 weeks ago. Young woman, 26 or 25, and was in hospital for 3 days. She could not get out of bed. Okay, so it's 3 days. She was hospitalized because of weakness, and she can't get out of the bed. Okay, so now that I expect you guys to know, I was told she's had surgery for weight loss. Not one of our patients, it was a different facility. So by me telling you this, young, healthy woman, she's now 5-6 years out from having weight loss surgery, she can't walk now. What do you think is going on?
I know.
No, don't listen. I want him to think it because we've talked about these things. She can't get out of bed. Her muscles are wasted. She's very weak. So these are all great, potentially possible things, but they don't present acutely like this, or semi-acutely, I would tell. Yeah.
How much did I stress that today? Probably about 5 or 6
Okay, so
times.
let me tell you what's going on with her. She was feeling great, young woman, had surgery. She's 25, 26, lost a good amount of weight, feels a lot more, healthy out there. She starts to feel, hey, this is fabulous. So I'm doing fine. I don't think I need to do this. And do you know how many times in clinic I meet with patients who, when I go through the list, are you taking this? This is what I get. Okay. Are you taking that? Are you taking this? Sometimes. Yeah, you get all sorts of body language and head down, head up, to the left, to the right. And even though you all go through classes, you get reminders, you have your vitamin levels checked, I want to tell you, there will come. This lady is not silly. She wasn't mad. Complacency takes over. You get comfortable. You get too comfortable. You're doing great. New job, new partner, traveling, like everything that you wanted to do, and you just say, okay, I'm feeling good. That's it. You don't take your stuff. Sad thing is, your storage of these vitamins lasts you for about a year, year and a half, 2 years max, some of them. You will become deficient. And the most significant deficiency that is hard to reverse is B1 and the B vitamin deficiencies, okay? And the problem is these are, some of them, really irreversible. I mean, when you get to that extent of a loss, your nerves are not going to necessarily regenerate. So, they're pouring in bags of vitamin to this lady, and her rehabilitation is going to be complicated. We don't really know how much of this she's going to recover from. So you cannot miss the things that you got to do, which are your multivitamins, your B12, your calcium, and some of you may have requirement for iron and additional supplements if we see that you're having shortage of those. So please take them. There is an element of truth in that. The only difference is that by the nature of the fact that you're eating less in capacity, you're going to have lower amount introduced. Your absorption improves, your capacity does go up a little bit, but the chance of you developing deficiency still is definitely there. It's less of a risk than bypass because bypass is more malabsorptive. But so most of us in the field go into this recognizing that you don't want to take a chance, and therefore to continue those routine vitamin supplementations throughout. But what you say, there is an element of truth in that, because your malabsorptive features with sleep is much less. There's less micronutrient changes of absorption. So yes, you will last longer without support, but it will eventually catch up with you. Again, when I meet with all of you in the practice, usually when you come to the 12 or 18-month visit, it does often come up. And, plastics has an image of being like an easy, go to the plastic surgeon, get the surgery, and go home. And a lot of times that may be the case. But you've got to remember his operation. You're under anesthesia. There is risk associated with plastic surgery, like it is with any form of surgery. And it actually does take a demand off your body. And I really need you to think of this before you make that decision. And for those of you who really have done everything, you exercise and you're suffering with excess skin or other anatomical changes that you want to address, that's fine. But don't forget, it is a big operation. Okay, if you're having an abdominoplasty, the incision is flank to flank. It's big cut. Second of all, it does allow essentially or it does cause your body to go through a stress response. And nutritionally, you have to be optimal before you go for these operations. Your level of blood count has to be optimal, which means your iron has to be optimal. Your vitamin levels have to be optimal, because some of these vitamins like vitamin C and vitamin A and some of the elements like zinc are important in your healing capacity. So sometimes I kind of get the patients who say, look, I really want to get this done, but they're not looking at the big picture. So in order to optimize yourselves, when you're coming up to these 18-month periods that you think, okay, I'm thinking about plastics, definitely self-evaluate yourself. Make sure that you're good with your protein intake, because protein, as you know, is #1 element in repair. So you got to make sure you have adequate nutrition supply with proteins. You got to make sure your vitamins are tip-top, especially younger females who are having menstrual cycles, that you're not iron deficient, that you've optimized your iron intake if you need to. So you have to either check that with your primary or with your bariatric surgeon, with the practice or whoever you're with. And you got to make sure that you don't challenge your body too much at once, okay? I mean, it's exciting, it's transition, and you perhaps have had problems and you want to get rid of it. But don't do too much at once. You know, I remember once one of our dear, dear patients had gone and consulted, and she had decided to have everything. She was a school teacher, and she had to have it because she wanted to recover in the summer and get back to school. She didn't want to have to break up the year to 2 different or 3 surgeries. And so she had thought about it. She knew it, but she made a choice to do it. I don't know if you remember. Do you remember? No, I thought. So she had chin, she had arms, she had thighs, she had abdominoplasty. I don't think she had done breast pexy or augmentation. And she walked in the office, it was probably 6 weeks post-surgery. And, you know, by then you should be a lot more mobile and active. And this was how she walked in, like this. You know, arms were sore, tummy was still sore, face was still swollen. It was a lot. Her blood count had dropped. And it took a long time, and I saw her, I think, at 6 months after, and she was fine by then. But it took a long time, and she said, I wouldn't do this again, okay? So really talk with your surgeon, plastic, and decide first what areas you feel you need to have surgery if you decide to have it. Make a decision as to really how you want to group it. Do you really need it? And find out your options before you kind of sign on that dotted line. And then make sure nutritionally you're good, and you follow up. You don't just assume that you have plastics and done. So one of the things that we want to do, and we've already started that, is we see the patients before they go through plastics, make sure that all of their parameters are checked, that all the nutritional is optimal. If they need to have corrections, that's done. Then they go through surgery, and then they follow up again afterwards to make sure that they're back on track with things, and not just kind of, you know, again, becoming complacent and not follow. Because it takes 3-4 months for your blood level to come back when you lose a unit. So you want to make sure that you do everything that you need to get that back up to normal, and you feel energized and you go from really strength to strength. So bear that in mind when you guys make that decision.
I want to expand on something you said, and it got brought up during class. You said it takes 3 or 4 months to replace a unit of blood. So with that being said, you guys should not be blood donors.
Right. Okay. You can donate blood products, though. You can donate platelets, for instance, but you can't donate your blood as in red cells. Yeah.
Yeah.
Well, because you'll become anemic and you play catch-up game all the time if you do. So when you have an operation that blood loss is expected, okay, i.e. they know that you're going to lose at least a unit or 2, really that depends also on your surgeon, because some have very good, you know, techniques and may be able to get away with surgeries with minimal blood loss. They know themselves. Some are traditionally a little bit, more prone to having cases that have requirement for blood transfusion. They may have a lower threshold to transfuse. So you have to have that discussion with your surgeon. If you talk to the orthopedist, says, listen, the last time I transfused the patient with a knee operation was 5 years ago. It's very, very unlikely that I'll need it. In those situations, it's of no value to donate your blood, because once it's donated, only will given to you, essentially, if it's needed. They're not just going to give it to you. Now, so if you are expecting a heavy blood loss, that's the kind of situation you'll donate your blood, they wash it, they prepare it, they have it ready for you, and they will give it back to you. And if you are going for an operation that blood loss is minimal, you don't want to donate your blood, because by doing that, and by the way, there's a timeline. You don't want to just do it like within a few days either. I mean, I can't tell you the policy because I haven't had to use it. But you don't want to also give up blood and then go to surgery a little bit low on your reserve. And if you're not going to have much of a blood loss, you've donated blood and not really needed to donate it. So the answer is, if it's a big operation, you expect blood loss, you donate it, and you receive it afterwards. Otherwise, no.